Hi everyone, welcome to the November Task 90, where the topic is Fundamentals of Rural Health Clinics. We'll get started in just a minute here. As a reminder, in addition to joining Adobe to see the presentations, please also call in to the audio portion of the conference. The conference room number and the phone number to dial in are both located in the chat box. As a reminder, phone lines are muted by default, so to ask a question, please press *2 to mute or unmute your line, or you can also enter questions in the chat box.
Good afternoon. This is Sally Buck, CEO at the National Rural Health Resource Center and Program Director for the Technical Assistance Services Center for the Rural Medicare Hospital Flexibility or FLEX program. And our Task 90 webinar today, our topic is Fundamentals for Rural Health Clinics. And we're excited to have Nathan Bowe from the National Association of Rural Health Clinics, or NARC, will be our speaker. First, we will get started with some program updates from Tasc, from the Federal Office of Rural Health Policy, and special policy and regulatory update, and then also hear from FLEX partners at Arcata and the FLEX monitoring team. And as Shannon noted, you can put questions into the chat box or dialing in. You can press *2 to unmute your line for questions, and the slides are available as a download on the side. So for Tasc, a few updates. We have been announcing and promoting that we have a critical access hospital recognition cycle open. We're looking for innovations in telehealth. And hospitals need to be nominated by their FLEX program, and they are, we have a little review committee that FOHP is part of, and our partners, so we encourage you to make sure you answer all those pieces of the nomination. So we're looking for telehealth projects, and we recently finished up a FLEX workshop in October. We had 11 states here, 13 participants, and also had Tori from FOHP attended as well. Really great discussion and speakers over the 3-day program. The next workshop will be in April. We are starting to plan the FLEX reverse site visit, or our annual FLEX conference meeting that will be in July in the Washington, D.C. area. We're close to sending out a save the date, just working on the contract, but the week we are looking at is the week of July 9th with the FLEX reverse site visit meeting for everyone on that Wednesday and Thursday, the 10th and 11th. And then finally, the Rural Health Information Technology Coalition, that is open to anyone interested in HIT and telehealth within their critical access hospital and rural health programs. We have a call on November 28th, and that's listed in our events. And we will be meeting face-to-face in February during the National Rural Health Association Policy Institute. I'm probably on that on Tuesday afternoon, February 6th, a face-to-face meeting as well. So I will introduce Sarah Young, our program coordinator for FLEX, who will be providing the update on CH regulations and the F4HP activities. And she's got a few slides. Go ahead, Sarah.
Hi, Sally. Thank you. Well, as you may have heard, the former F4HP policy coordinator, Joaquina Scott, moved to another position here at HRSA, so she won't be providing these updates anymore. And as a stopgap, I'm circling back on these for everyone also. So this is information from over the last 3 months from the F4HP policy team, and we're trying to highlight some of the recent regulations that are particularly relevant to critical access hospitals and flex programs. So first, we have a proposed rule that the comment period closes next Monday, where CMS is seeking comments on proposed changes to the conditions of participation and conditions for coverage for a variety of healthcare providers and suppliers. There were several cost-specific items included in the policy changes they were seeking comment on. And for all of these policy updates, of course, you can get more details in the monthly policy updates that are part of our Rural Route newsletter and the weekly F4HP announcements. The second proposed rule that is currently available for comment, and this comment period closes the end of December, is proposed rule on policy and technical changes to Medicare Advantage and the Medicare drug program, as well as PACE programs and Medicaid managed care. And it's primarily seeking comment on implementing provisions from the Bipartisan Budget Act of 2018, last year's budget bill. And a couple of things to highlight out of that, especially proposing expansions to Medicare telehealth benefits for Medicare Advantage plans. Then there are 3 recent final rules that I want to make sure everyone is aware of. First is the annual payment update for the Home Health Prospective payment system. If any of you have rural hospitals that are working with home health or operating home health services, good thing to know about. It's ways down the line, but the new patient-driven groupings payment model for home health will be implemented in calendar year 2020, and this proposed rule sets up a lot of the planning for that. And there are several home health rural add-on payments that are currently in effect that gradually phase out and then sunset over the next 3 years. And again, that is following the most recent budget bill. A massive final rule on the physician fee schedule and the quality payment program for calendar year 2019 was published maybe 2 weeks ago now, and there's a whole lot of other provisions in this rule, of course. If you want to know more, I encourage you to see the most recent policy update from our policy team, because they went into a lot of depth on it. A couple of things to flag. Again, this is primarily about physician fee payments, but it does make a bunch of changes to expanding telehealth services and sets up, again, over the next 3 years, a transition on how evaluation and management billing is paid. And this is the billing for the regular physician office visit that is one of the most commonly billed services in Medicare. Then the proposed rule that probably has the most direct impacts on the Flex program and on critical access hospitals, is the Outpatient Prospective Payment System proposed rule, because a number of the hospital policy changes that CMS makes in that rule can affect critical access hospitals and other rural providers, of course. As always, this was the calendar year 2019 payment rule, so it updates Medicare payment rates for all of the covered entities under the rule. And major change, again, this one does not directly impact critical access hospitals because they're not paid under OPPS, but I think it's something we all need to be aware of, is this modification to how payment for outpatient clinic visits is going to work, changing it from the formerly standard OPPS rates to outpatient visit payment rates, again for evaluation and management services that are equivalent to the Medicare physician fee schedule output payment rates, and that's going to be phased in over a 2-year transition. And the proposed rule also made some changes to how 340B program, drugs acquired through the 340B program are paid by rural hospitals. Again, this is a change in the OPPS payment rate for covered drugs, so it will not affect critical access hospitals, but it can accept other rural hospitals who are participating in 340B. And of significant interest for us in IndyQuip, this rule removed 8 measures from the hospital outpatient quality reporting program, some of which were IndyQuip measures. And our partners at Arquita will be providing more updates today and over the next coming weeks about how those measure removals will impact IndyQuip reporting and how they'll be phased in. If you have any other questions about the policy updates, please, I can try to field anything right now. And of course, follow up with detailed questions at our rural policy mailbox, ruralpolicy@hrsa.gov. That is a great way to get in touch with the 4-HP policy team, who are the folks who really look at all of these rules in depth. So with that, are there any questions on these quick policy updates?
Just a reminder that it's *2 to unmute your line if you have a question. Otherwise, you can use the chat box.
Thanks, Sarah. Do you have other 4-HP updates?
So on the Flex program side, first I wanted to say thank you to everyone who has updated their Flex profiles for the Tasc website. That is a really heavily accessed part of the Tasc website and is an important way for Flex programs to share information with each other and with outside stakeholders you may not even realize who are looking for your information and materials. So thank you to everyone who has completed those. Your project officers are reviewing your PIMS reports and are in the process of reaching out to you if they have any questions about what you included on your PIMS report, and we will continue getting those reviewed and finalized. I believe we have about 20 of the PIMS reports are completely finalized right now, and a number of others are just getting their final edits. And an update for you, the Flex notice of funding opportunity for the upcoming FY19 calendar year, so the next application period, continues to be in the HRSA clearance process, and I hope that it is on track to be published December 3rd as scheduled. Of course, that's subject to change, but we're hoping we're going to be able to stay on track with this one. Any other Flex program operations type questions?
Sarah, is it appropriate to share this kind of save the date for the NOFO webinar on the
yeah,
grant?
That is absolutely fine. And I believe Shannon has already posted them on the Tasc website, actually. Thank you, Sally, and thank you, Shannon. We currently have scheduled TA webinars for the primary Flex NOFO and for the EMS supplement notice of funding opportunity for December 11th and 12th. Of course, those dates are potentially subject to change if the publication is delayed, but assuming it's published on time, we will look forward to catching up with everyone the next week to go over those notices in detail and to answer your questions. If you want more information, see the Tasc website.
Yep, great. Thanks, Sarah, for getting, just in case the folks want to keep those dates on their calendar. And we can even post the link up there. I can put that in the chat box. Okay. Are there any other questions? I'll move now to update from the Rural Quality Improvement Technical Assistance Center. Sarah Brinkman from Stratus Health will be providing an update. Sarah?
Yeah, thanks, Sally. So I first have to apologize for any background noise. I'm working from home today. There might be some coughing in the background. Just a few updates from us. As many of you are aware, we've been conducting one-to-one calls with each 45 state flex programs over the course of the last couple of months, and we're looking to wrap those up in the next few weeks. So thank you all for your prompt response and for scheduling, and in some cases rescheduling when necessary to get the appropriate folks on the line or to make sure everyone can participate. They've been really helpful for us, and we're looking forward to utilizing the knowledge that we've gained through those one-to-ones, learning more about each of your MVQuip programs and your flex programs and how things are operating to inform our work plan going forward, and hopefully to help make connections between states if there are questions or opportunities there, and also to highlight some of the great work that each of you are doing on MVQuip VKGs, maybe at the reverse site visit in some fashion, at other conferences, etc. So thank you for that. We did push out after our November MVQuip virtual knowledge group call the schedule for the 2019 virtual knowledge group calls, and it was noted that one of them was scheduled during the time when there would be a conference that would be in direct conflict. So we are working on an update to that, and we'll be sending out an updated schedule probably next week when we distribute the MVQuip monthly newsletter to you all. As Sarah Young noted, there's been some final rule changes that have come out, so we are working on one of those measure summary updates for you all as it relates to the outpatient prospective payment system final rule and the measures that have been removed by CMS that were part of MVQuip. Suffice it to say that for the time being, all of those measures are still included and are core, and and they are able to be reported. So for as long as CMS will accept the data, they'll be considered core measures for MVQuip. So there's nothing to do at this moment. All of the data that your hospitals are working on collecting right now is still appropriate, and we'll make sure that you have all the information you need before any of that changes. And then my final update is just a reminder that we relaunched the Abstraction for Accuracy offering following the pilot that we did last spring. That's an opportunity for hospitals to have Robin, who is our quality reporting specialist, review their abstraction through reviewing their actual records that they've abstracted and doing a cross comparison, a side-by-side of what she abstracts versus what they submitted to see what the percent agreement is and where there was disagreement. And then she does a one-to-one consult with each of those hospitals to review the results and identify opportunities for improvement at the individual facility level. And we do a roll-up of that information at a higher level to help us understand what's happening nationally and what we might be able to focus in on as far as further education and resource opportunities. So those are kind of our big updates. We will be pushing out, as I mentioned, MVQuip Monthly next month. We'll actually be taking a break on MVQuip Monthly in December, and we'll be relaunching and having it come out at the beginning of the month rather than at the end of the month, based on some feedback that we got from our assessment that you all completed in August. So thank you for doing that. And we'll send out more information about what that schedule change will look like with the November edition next week. That's all I've got.
Thank you, Sarah. Any questions for Sarah at Arquida? And again, the events, as they're scheduled for MBQIP topics through our KETA are posted also on the Tasc events page too. Okay, next we'll move to the Flex Monitoring Team update. That'll be John Gale.
Yes, hi Sally. Good
Hi,
afternoon,
John.
everyone. Can you hear me?
Yes, go ahead, John, and then we have the document on the screen as well.
Well, I can be a little elaborate a bit more than the document. We've got a number of different products that have been recently released that are already on excuse me, the Flex Monitoring website. The quality peer grouping indicators, the CAH financial indicator reports and tools, the stroke quality improvement activities in CAHs, and most recently a policy paper looking at the alignment between the critical access hospitals community health needs assessment and implementation plans and how they're doing what they're proposing to do as part of that. So they're up on the website now. Within the next 2 to 4 weeks, we should be getting out a number of other products. We have an update to the Critical Access Hospital Community Benefit Activity Report that we've done in the past that will look at how and what they're doing around community benefit activities and some opportunities for flex programs to become involved. We will have another brief on state flex activities related to time-critical diagnoses that has been reviewed by the office. We're making comments now, making the adjustments now. And finally, a brief on the innovative healthcare models that were taken on under Program Area 5. So they'll all be out sometime, hopefully within the next 3 to 4 weeks at the latest. Moving forward, the last policy brief that's in the works is looking at the role and the framework for helping CAHs think about addressing and how they address substance use in their communities. On a larger scale, we're moving forward for the activities for the current year. We're updating and working to enhancements to the quality and community data displays in Compass. Some of you may not be aware, know the ins and outs of it, but the ability to provide data, because of the limitations of data from quality and community, that's not as easily done at the hospital level as the indicators, financial indicators, which come directly from the cost report. So we're really working with the University of Minnesota on a new way to display that data, and so that'll be rolled out this spring. We're also, in the springtime, somewhere around March, we'll be doing the annual reports that we do around financial activity, quality, and community performance. And we have one request, I think, coming from all of us in the Flex Monitoring team. We've been working closely with the office to do much more of an evaluative work on state flex program activity and to get a handle on the impact. So we have 2 on quality indicators and quality improvement activities of state flex programs. And we're updating with University of North Carolina, the past brief that we did on financial and performance improvement. And we're really going to be digging in a little bit more to that, using the PIMS data and the state flex applications to really hone in on how to monitor the impacts. So you will be getting calls from probably some of the centers. We'll try not to front load too many of the same states, but we'll be asking states to help us talk about the things that they're doing and really try to identify some best practices. So that's all going on this spring. And last, we've got a couple of other projects that we're doing related to how provider-based, critical access hospital provider-based RHCs are engaging in mental health activity and what models they're following. And then continuing our work with the activities of CAHs related to the opioid crisis. And UNC's last project is really looking at the characteristics of communities served by CHs are at risk for financial distress, and some of the activities that can be done to support those communities. So we've got a full agenda, and as always, we're available for questions around any of the work that we do, and happily answer those questions. So you can either contact me or our other team members within the monitoring team.
Great. Thank you, John.
You're welcome.
Any questions for John, Flex Monitoring Team?
Okay. This is Sarah. I just wanted to say thank you for joining the webinar today, John, and reiterate what you said in the context of the upcoming Notice of Funding opportunity that folks will soon be writing applications for. The Flex Monitoring Team and their products and publications are resources for Flex programs. And just like the Technical Assistance Services from Tasc, I really encourage everyone to reach out to the FMT folks and both ask them questions and use their products and publications as those make sense to incorporate in your program planning and application writing.
Thank you. I should mention one last project that I overlooked. We're having our first conference call tomorrow night with a panel, tomorrow afternoon I should say, with a panel of EMS stakeholders, some from the state offices and Flex programs, from FORHP, from Tasc. We're going to revisit some of the measurements and data issues for rural EMS performance improvement. We've done a fair amount of work in this area, and there are real data challenges, as you all know, working with EMS. So we are going to be looking at available data sources and trying to help work with experts to figure out what sort of data we might be able to mine. We have the run reports filed by the individual EMS agencies, but are there other data sources? So what do states collect around their licensing and regulatory obligations that might really give us more than we know? I think the last great frontier of rural health monitoring and rural health improvement monitoring is around EMS. What are they doing, and how do we help them to move forward? So we appreciate the folks from the State Flex programs and Nicole from Clement from Tasc, and we'll be moving that project forward as well.
Great. Thank you, John. Very timely with the special EMS projects available through the State Flex program grant next year.
Yes, we hope so.
Great. Yeah. Okay, well, now we'll move into our topical portion of the Task 90 call. And Shannon's putting up a pre-topic question as we work towards assessment. We find that doing that pre-post polling helps us better assess the effectiveness of the webinar in providing knowledge and then knowledge gain. So if everyone can just quick fill out the scale there, one response per person. And while you're doing that, I'll just provide a little bit of background on the topic for fundamentals of rural health clinics. And we felt this topic would be timely as we're continue to see more critical access hospitals have provider-based clinics or have rural health clinics present in their communities, and many of our Flex programs, our state offices are looking at how can they provide technical assistance to a growing number of rural health clinics. So we felt having an expert on rural health clinics provide some background on the history of the program and the eligibility to be certified as a rural health clinic and how that impacts their payment structure. And this webinar portion will set the stage of rural health clinics and the basics and how critical access hospitals interface with rural health clinics. And then we plan to do a virtual knowledge group call early in 2019, and we'll identify a couple state flex programs who do work directly with rural health clinics and have them highlight the technical assistance and resources that they're providing in the flex program in one of the core areas. And so we have also been asked by FOHP to make sure our TA resources and information considers rural health clinics as we work towards planning our topics, especially in financial improvement. In this past summer, when we had a summit on the top financial indicators, it wasn't only looking at critical access hospitals, but also rural health clinics. And we had an update to the CA Finance 101 guide, which has been such a popular resource the past 6 years, that it was updated to include the financial components of provider-based rural health clinics. So this is kind of another step we're doing to broaden awareness and understanding of rural health clinics and how they work with CHs. So I'm going to turn the slides speaker over to Shannon Norman. She dove into looking at the last round of grant applications from the state flex programs as they were categorized during the review process to just see how many states were working in this area. So I'll let Shannon explain her findings.
Thank you, Sally. So I'll keep this really brief. I don't want to take any time away from Nathan, but we thought it was important to sort of set the stage for the work that's already being done out there by flex programs with rural health clinics. So we were able to identify 7 state flex programs that are providing support for critical access hospital-owned clinics. And 21 state flex programs are providing support for provider-based rural health clinics. So as Sally mentioned, and as you can see here, there is a difference between the critical access hospital-owned clinics and provider-based RHCs. For today's webinar, and then also the January virtual knowledge group, will be focusing specifically on provider-based RHCs. And within those, 18 different states are working in finance, 5 states are supporting them in quality, 3 states in innovative care models, and 1 state is currently in population health. As you can see, since there are no states currently supporting them through EMS, and with the supplements that are currently out there, that's a great opportunity for those of you who are looking for ways to offer resources, education, and TA to your cause and rural health clinics. I also want to take a moment just to highlight a couple of resources that are on our website. One of them is from RHI Hub. It's a rural health clinic guide. It's a really great overview, and we'll touch on some of the things that Nathan will go into today. So if you're a little bit unfamiliar with rural health clinics, that's a great way to learn a little bit more about them. And then there's also a fact sheet that just came out, and that one is published by CMS. You can also find that on our website. I will go ahead and post these links in the chat box as well, so make sure you bookmark those or utilize them as resources as well. And does anyone have any questions on that before we welcome Nathan?
Okay. Thank you, Shannon. Our speaker today, Nathan Bowe, is the Director of Government Affairs with the National Association of Rural Health Clinics, or NARC, and he has worked for NARC since April 2014. He does advocate on the Hill and to CMS on a wide range of issues impacting RHCs, and through the work in NARC. NARC is the only national organization dedicated to exclusively improving the delivery of quality, cost-effective health care in rural underserved areas through the Rural Health Clinic program. And NARC provides technical assistance to providers and hospitals regarding rural health clinics, and is a membership organization as well as having technical assistance cooperative agreement with F4HP. So we'll pull up Nathan's slides, and you have presenter rights, Nathan. And star 2 to unmute your line.
Hello.
Yep. Hi, Nathan.
Hi, everyone. Thanks for having me. And I guess I'll just dive right into it as long as I can change the slides here. Great. So we're going to start with some of the fundamentals of our, I'm sorry, is the intro done?
Yep, go ahead.
Okay. All right. So I'm going to start with some of the fundamentals of the Rural Health Clinics program. Then I'm going to pause. We're going to have time for questions, and then I'll get into regulatory update, which actually was already briefly touched upon in, I believe, Sarah's presentation that kicked us off. And then I'm going to talk about some stuff that we're working on legislatively, just to make you guys aware. And then we'll have hopefully some time for questions at the very end as well. So, you know, every entity, cause, rural health clinics, these programs, they all have an origin, right? And the rural health clinics origin was in 1977. It was signed into law by President Jimmy Carter on December 13th, 1977. And this is a picture of the actual signing. I found this on the physician assistance website. I don't know who all the people in the background are, but I'm sure that that is President Carter right there on at the desk. I'm assuming those are congressmen and senators that were instrumental in passing this law. And before I dive any further, I noted that a lot of people said that they were either neutral or somewhat unfamiliar with provider-based rural health clinics or and things like that. I would actually say the same about the Flex program. So hopefully we can sort of bridge this gap, because I know even in rural health, there are so many silos and niches, I should say, that it's good to have that cross-cutting understanding of how does the Flex program relate to the State Office of Rural Health, relate to critical access hospitals, to rural health clinics, etc. So hopefully you guys can help me bridge that gap from my perspective as well. All right, moving on. So I think the purpose of the Rural Health Clinics program is actually very similar to, what the Flex program aims to do and what critical access hospitals, what their mission is. But I thought that President Carter's statement, which I had to dig up, but I thought his statement when he signed the Rural Health Clinic Services Act was actually pretty accurate in describing what the goal of the program is. I'm not going to read the whole thing, but I'm going to paraphrase here. Basically, he's saying that our healthcare system is great, but only at the best, and we have very much uneven distribution, right? Whether today you're talking about Medicaid, is the quality of Medicaid insurance as good as Medicare or private payer insurance? How do people without insurance access health care? We have a lot of the same problems today. But the Rural Health Clinics program aims at addressing this in rural areas by using PAs and nurse practitioners. And that is a key component ever since the start of the Rural Health Clinics program. It was we have a requirement where at least 50% of the time you have to have a PA or a nurse practitioner providing care in the clinic, right? So the thought was that, well, maybe we can't get a physician into this town, but we can support a PA or an NP. And at the time, PAs and NPs, these were actually professions that were just starting out. So the Rural Health Clinics program was one of the first federal programs to really utilize these types of healthcare practitioners. And as he goes on to sort of conclude here, is that our payment policies don't necessarily allow for a clinician to sustain a practice in a rural area. So the Rural Health Clinics program was designed to allow for a PA, an MP, for a physician to live and work and practice in rural underserved areas feasibly, right? So they're aligning Medicare payment to make that a reality. So I love this statement. I think it captures sort of the essence of rural health, not just rural health clinics, but all of rural health can sort of be
Nathan?
captured in this. Yes.
This, Sally, you know, I think the kind of the parallel with the critical access hospital legislation, which came 10 years after this, you know, in the following the Balanced Budget Act, also recognize that in areas of low volume, there needed to be a different model. And although it wasn't specifically to the types of providers, it allowed that same cost-based reimbursement that rural health clinics have for Medicare and in some states Medicaid as well, you know, if they meet certain criteria, which I know you'll get into in the rural health clinic. But I think that's one of the, you know, the biggest overlaps is they're both safety net providers.
Yeah, absolutely. Yeah, I think, you know, what he's saying here is applicable to a lot of safety net providers, whether it's CAUS, FQHCs, although FQHCs was created later. I do believe rural health clinics was one of the first safety net entities created by the federal government. I'm going to go over a brief history and profile what has happened since 1977. Unfortunately, and I'm going to get into this at the very end, but the program has not been updated in some way since 1977, and we are working on modernizing the Rural Health Clinics program. So that's a preview of the legislative initiatives that we're pursuing. But initially, the program it didn't explode rural health clinics in the early 80s, or there were I believe about 500 or so clinics. Almost all of them were independent rural health clinics when the law was first signed. When the hospital payment system switched to the PPS system, though, we started to see a lot of rural health clinics pop up. So the late 80s and the early 90s, the number of rural health clinics in the country grew significantly. And this was because there was no cap on, well, there's several reasons, but one of the reasons was that basically people figured out that if you owned these rural health clinics as a hospital, you could you know, put some costs into the rural health clinics, get reimbursed for that, and it was sort of a way to subsidize a hospital payment. This led to some turmoil in the late 90s where there was an OIG report and basically some media pressure and congressional heat on the rural health clinics program. You know, in the intervening period, we had the CAUS program created and some other things to address sort of supporting hospitals in rural areas. And so some people thought that the rural health clinics program was being abused in the 90s. So they wanted to sort of restrict payment to rural health clinics for everyone. And there was a lot of back and forth. And what we settled on, and this is a key point that I'm going to harp on a lot, after initially they were going to cap everyone, and then but it wasn't going to go into effect for several years. Then we were NAREC and others were able to basically carve out those rural health clinics that are owned by small rural hospitals. So they said, okay, we buy your argument for the large hospitals, but in the late 90s, there was still a rural and small hospital closure issue even then. And so we were able to successfully argue to Congress that these rural health clinics help keep these hospitals open, help keep these small rural hospitals open. So Congress exempted clinics with or clinics that are owned by hospitals with less than 50 beds from the payment caps. I'm going to get into the payment caps because that's a key part in more detail later. So we were kind of able to get through a little bit of a troubling time in the late 90s and early 2000s, relatively well. The program has continued to grow. I want to say ballpark there was under 3,000 rural health clinics in the turn of the century, and now there are over 4,400 rural health clinics, and that number does continue to go up. So that is a positive sign to see that the model is still working for many folks in many areas of the country. But there are several key challenges. We have some outdated billing methodologies. We have some odd billing practices. Is trying to do X, Y, or Z. They have to come up with a workaround for rural health clinics because we bill differently. So there's some key challenges that remain, but perhaps our biggest challenge is that we have sort of an outdated program and outdated payment systems on the Medicare side, and I'll get into that later. Some of the basic requirements, like what do you need to be a rural health clinic? Obviously, you have to be in a rural area. For us, that's defined as any area that's not an urbanized area or 50,000 people. So any area that's not designated by the Census Bureau as a quote-unquote urbanized area is therefore considered rural. And that's the first location requirement. Second is the location has to be in a shortage area, and that can be a medically underserved area. That can be a geographic health professional shortage area, it can be a population health professional shortage area, or it can even be a governor's designated shortage area. So there's several different ways, but that's basically just saying that there's not enough practitioners, there are not enough clinicians to serve the population, right? So it has to be located in one of those, or both of those location requirements apply, so you have to have both. And once you, the clinic almost has to be up and running before you can apply to be a rural health clinic. So once you're up and running, you can go apply for a rural health clinic status. And you have to go through a whole survey and certification process to ensure that you comply with all the different rural health clinic rules, some of which have not been updated since 1977 and we're trying to get fixed. So some of them don't make a whole lot of sense, but most of them are still, they hold up decently well. And that is, I note that because a lot of fee-for-service clinics or offices don't have to go through a survey and certification process. So this is an extra layer that you have to demonstrate that you're complying with all these rules in order for you to be able to bill and get the benefits of being a rural health clinic. One of the requirements is that you must primarily perform primary care services. You also, as I already mentioned, you have to use an NP or a PA at least 50% of the time the rural health clinic is open. Rural health clinics, unlike FQHCs, can be for-profit and thus can be owned by hospitals and CAUs, right? So that's a key distinction. I don't believe that there might be some loophole exception on the FQHC side, but by and large, a hospital cannot own an FQHC, unless I'm mistaken on that. But I'm pretty sure that the FQHCs, it's not really an option for a college to open the FQHC. It's an option for a college to open an RHC, though, because we are allowed to be for-profit, and it can be nonprofit. It doesn't have to be, but FQHCs have to be governed by like a board of directors and things like that. So we don't have some of those requirements. And like I said, it can be owned by the hospital or the physician themselves. Why would you go through all this? Why would you go through that survey and certification process and figure out what's going on with, how to get your rural health clinic status? Well, you get cost-based reimbursement. So you guys are familiar with how CAUs get reimbursed. They get 101% of their costs based on a cost report. Rural health clinics get have a very similar payment structure. We have a cost report, and we get reimbursed a single all-inclusive rate on Medicare. This is Medicare now. We get reimbursed the same amount of money for every single service throughout the course of a year, right? And so what clinics call that is the Medicare all-inclusive rate, right? And that is, again, calculated on your costs and the number of visits that the clinic had last year, right? So it doesn't matter what the CPT code says, unlike fee-for-service, right? If you did a level 5 E&M code or a level 2 E&M code, it doesn't matter, right? You are still going to get the same reimbursement rate if you're in a rural health clinics. The calculation is then done for the next year, right? And you'll get a set rate for the next year. On the Medicaid side, it's obviously varies state by state, but there's a federal floor. And this was established in 1999/2000, basically saying that the states can pay rural health clinics and FQHCs. We're in the same boat on this particular issue. They can pay them however they want. The states can come up with any sort of methodology in regards to Medicaid. But that payment cannot be lower than this sort of federal floor, which is the costs as they were in 1999 and 2000 trended forward for inflation. So generally, varies again state by state, but generally it's a lot better than your fee-for-service Medicaid payments. In fact, rural health clinics are much more likely to see Medicaid patients timely because the payments are a lot better. They're happy to have Medicaid patients come in to the door, whereas many other fee-for-service clinics, it's just a fact, but they sort of they ration care almost because they can't have, a large Medicaid population because it doesn't pay enough. That's not the case for rural health clinics. So there's those two big incentives, right? It's basically you get this Medicare all-inclusive rate, and then you get this Medicaid payment. Again, it varies state by state, but it's generally going to be a lot better than your fee-for-service payments. As I've already noted, we are not fee-for-service. And because of that, it's beneficial in some ways, but it's also leaves us out of certain things. For instance, Medicaid, the MACRA, this is 2015, not 2018. I should fix that. But MACRA doesn't really apply to rural health clinics because we get cost-based reimbursement, and MACRA is largely directed at fee-for-service payment programs. So we're largely, as rural health clinics, left out of those quality initiatives such as MIPS and advanced APMs. There's limited ways that rural health clinics might be able to participate, but we don't really get the same carrot and stick that a fee-for-service provider would, because we have this cost-based reimbursement which isn't affected by these quality programs. So we have a very sort of weird relationship with what's going on the quality side of payment policy. Like I said, you have to file cost reports. I'm assuming everyone is familiar with cost reports because CAWs have to file cost reports. In fact, all the CAW owned rural health clinics, it's just a section, I believe it's worksheet M or S, I forget which one, but it's one of the it's basically built into their critical access hospital cost report. So you file it, and there's an RHC section which will dictate what the rural health clinic receives. I'm going to read this question here from Randy so I don't get ahead of myself. So regarding the utilization of nurse practitioner or physician assistant, is that saying that an MD or DO cannot substitute for those positions? That's exactly it, Randy. Some people are not a fan of this rule because it does require, so if you had, for example, an MD who wanted to open up a rural health clinic in a small town, he would not be able, or he or she would not be able to practice alone. They would have to have a PA or an NP in the rural health clinic at least 50% of the time. And so that is a provision that some folk, we don't really get into this fight because it's a bit of a scope of, I don't know, it's not a scope of practice, but it's kind of for the NPs, PAs, and the physician community to work out. The program was initially designed to sort of use NPs and PAs, and that's kind of always been the way it is. But yes, you're correct. The MD and DL cannot. Now, you can definitely have those folks work in the rural health clinic. In fact, many rural health clinics have several doctors. Some of the bigger ones have several doctors, 10, 15 doctors. So like large medical practices, it is seen, but and those practices would have to have at least one PA or NP. All right, so here's the big, so this is the big issue here with, we have a cap on the all-inclusive rate. So as I mentioned before, we have the cost-based reimbursement, and we have this Medicare all-inclusive rate. But the big caveat is that we have a cap on what that all-inclusive rate could be. So if you have cost per visit that are above, let's say your cost per visit for 2018 were $110, and you do the cost report, etc., that's what it comes out to. There is a cap on what your reimbursement can be for the next year, and that's for 2018, it was $83.45. It gets adjusted by inflation. That cap isn't applicable to you guys because you're critical access hospitals, and but it is applicable to the rural health clinics that are owned by large hospitals or that are freestanding or independent, right? And so the way the law is written, and this is straight from the Social Security Act, is it's just this parenthetical, which I've bolded here, right? It says, in establishing the limits under Section A on payment for rural health clinic services, other than such clinics and hospitals with less than 50 beds, the Secretary shall establish such limit. We call it a cap for services provided, right? And then it was set in 1988, and basically it hasn't been changed since. So it was $46 in 1988, and it's just been trended forward by the MEI, Medicare Economic Index, ever since, right? And that results in a relatively low payment today, right? So this hasn't necessarily aged very well. For your critical access hospitals, though, they have less than 50 beds, and therefore this cap does not apply. So if they have cost per visit of $150, $180, they're going to get that full all-inclusive rate, that full cost per visit for the next year. They're not subject to this cap, right? So that is I think one of our biggest issues today is how low this cap is for freestanding and clinics owned by large hospitals. Medicare, I don't know if they're going to go through with this or not, but they have been talking about collapsing the E&M codes. I think they were going to do it initially, and then they delayed it a few years, so they might continue to indefinitely delay this proposal. But they were going to collapse the E&M codes, I think level 2, 3, 4, and 5, into one single payment code, and that proposed payment was going to be like $94, right? And this was in the proposed rule. They didn't finalize it like that. But that just shows you how low this cap is. So you're going to pay $93 for a fee-for-service clinic for providing an evaluation and management service, but rural health clinics are capped at a lower rate. There's not really a Medicare incentive at that point to be a capped rural health clinic, to be a rural health clinic subject to this upper limit described here. So this was a really big problem for us, and it still is a big problem because that cap, $83.45, is very low. It's very low. So we're working overtime to get that increased. Those are the basics. So I wanted to pause there before I get into the like a regulatory update and a legislative update. I wanted to pause and see if people had questions about the basics of rural health clinics. And I see, okay, Kyle, I thought Kyle was going to ask a question. Feel free, if you guys have a question and you want to type it out while I'm doing the rest, I can stop and address it. So I'm just going to dive into the next two parts, which is I'm going to first talk about the regulatory update, and then I'm going to talk about a legislative, some of our legislative initiatives, which I've already previewed. Sarah mentioned this briefly in her opening, and I don't want to go into the nitty-gritty details of this, but this is an example of how what happens in the fee-for-service world there has to be sort of a workaround to bring it to RHCs because we use a different form for billing. We get a different, we're not in fee-for-service payment mindset, so things don't necessarily flow when they create a new benefit or a new CPT code and they want rural health clinics to do it. They don't necessarily flow down. We have to create a workaround. And the best example of this is chronic care management. I don't know if folks are familiar with the chronic care management benefit, but this was something that CMS created maybe about 4 or 5 years ago. And for several years, rural health clinics always lagged behind. What fee-for-service clinics could do, RHCs and FQHCs couldn't do until the next year. And the benefit continues to evolve. Today, just as an example, the rural health clinics and FQHCs can only bill this one code. It's a G code, G0511. Fee-for-service clinics can bill these 4 different codes. Each pays different, and each describes a different service, but for RHCs and FQHCs, we bill the one code, which means that we provided any of those 4 services, right? And there are reasons for that, but I don't fully agree with those reasons, but that is how CMS set it up, right? So, and we, instead of getting the different rates, we just get the average rate, right? So in 2019, the average of these 4 chronic care management codes is going to be $65. But I put this in, I left this in here because I just wanted to use this as an example. What happens in the fee-for-service side doesn't necessarily flow to RHCs and FQHCs neatly, and this is just an example of that. Stephanie said, on a national level, where do you feel is the most need for provider-based rural health clinic technical assistance? Well, I would say that there's coding and billing is always the number one thing that I see that there's demand for, because exactly this reason. If someone is coming from the fee-for-service world, or maybe they work in a health system that has rural health clinics and some fee-for-service offices, and they shift from one to another, there's a lot of confusion. Wait, why did the rural health clinics do it like this? So there's that billing and coding is certainly a big need of technical assistance. And then I would say the survey and certification. I forgot to mention this, but in addition to this survey and certification process that you have to undergo initially to get that RHC status, you have to get resurveyed every 3 to 4 years. So at any point in time, a surveyor could walk in and say, all right, we're doing a survey, right? So being prepared and making sure that you're always up to date with the RHC regulations, that's another big need for RHC technical assistance. And a lot of that is for independent and provider-based RHCs. I would say maybe specifically for provider-based RHCs, some of the cost report stuff can be really complicated. How do you, what should you put the costs over here or over here when you file your cost report? So that's another area that specifically for provider-based that I would say that you need some technical assistance. Jill says, I've heard when they become an RHC, they need to have a lot of financial backup because it takes a while for the payments to come in. Yes, Jill, that is dependent on your state. It can take a while for you to get RHC designation. Some states basically don't have surveyors ready to come, so you can wait. You can end up waiting for a long time for a surveyor to show up, which obviously delays the enhanced payments that you're going to get because the surveyor never came and you're still operating as a fee-for-service. So some folks choose to just hold their claims until such time that they get the RHC status so they can bill it under the RHC methodology. And so obviously if you're not submitting claims to Medicare, you're going to have to sort of dig into your rainy day fund, right? The other option is, of course, to just bill as a fee-for-service clinic, and then when you get your RHC rate, you get your RHC rate, and then you go from there. But some people, because they think the Medicare payment will be a lot better, they think it's worth it to hold those claims, and if they have the cash flow to pull it off, they can hold those claims for what I think Medicare allows, like a year, and then they file it once they get it. I will note that there's ways to speed it up, at least the survey and certification part. You can hire an accrediting company. There's two. It's Quad A and the compliance team. They, obviously you have to pay for that, but they will come survey your clinic, and that's a way to speed the process up if you think that your state has got a big backlog of surveys. All right. So the other thing that I will mention is the other part of the new, this is again another example, but this is a new benefit that CMS is bringing to all of Medicare, and that's this communication technology-based or remote evaluation services. And this is a new benefit starting in 2019, so it's not even billable today. But once again, what fee-for-service can do, not the same as what RHCs and FQHCs can do. We get the average of these two payment or CPT codes. It's G2012 and G2010. Point is, we get the average of the two. We can't bill those two. We have to bill our own code, which is G0071. What is this? It's a way for Medicare to try to save money, right? They are basically saying that if a patient calls a clinic and they're not sure if they should come in for a visit or not, and they have a 5-minute conversation with the doctor, with the clinician, it could be a PA, MP, one of the RHC practitioners, not the nurse, but one of the RHC practitioners, then that is now a billable service, only if it does not lead to a visit within the next 24 hours. So you can't say, oh, come into the clinic, that wouldn't count. But if you tell them to go to the ER, say, Mr. Baugh, that sounds really bad, go immediately to the ER. Or if the conversation is, well, maybe you should go see a specialist, as long as it doesn't lead to a RHC visit in the next 24 hours, this is now a billable service. So once again, we have this new codes that Medicare is creating to sort of promote this new idea of, new types of healthcare that are not just office visits, right? This is a phone call that's now a billable service. Medicare is paying for these phone calls. They don't flow exactly the same to RHCs. So you have to be aware of how it's different for RHCs and FQHCs relative to the fee-for-service side. Going to the question here, I've heard that when they become an RHC, they need, oh no, I already said that. You pay for that, but it is reimbursable on the cost report, right? Stephanie, I'm not sure. I think I lost the context of what you're talking about there, so maybe call in at the end and ask me over the phone. All right, I do want to get to our legislative update in my remaining time. I'm going to 4:20, right? Or 3:20 your time?
That's right, yep.
Yep.
Okay. Senator Hatch is retiring. Incoming Senator Mitt Romney is taking his seat, but Senator Hatch is the chair of the Senate Finance Committee, and he has made it known that he wants to do, as sort of his last hurrah as a senator, he wants to do a rural health package. So, and he made this known in the spring of this year. And that resulted in a hearing, the Senate Finance hearing, and I went to it, and it was a great hearing. They, we're talking about rural health, and I'm sure everyone that's involved with hospitals would be really happy because it was entirely focused on hospitals, rural hospitals, critical access hospital. Flex program was mentioned a lot. Again, I don't have the understanding that I should have with the Flex program, but I know it was mentioned a lot. And I actually got a little discouraged, though, near the end because there was not a discussion at all about rural health clinics. It was like outpatient care, primary care. It wasn't even on the radar for anybody. However, the very last basic round of questions was from Senator Wyden from Oregon, who's the ranking member for the Democrats. And he noted, and this is a quote, "We've been at it for almost 2.5 hours. You all have been terrific, but what I'm struck by is I don't think we've mentioned over the course of 2.5 hours what is really the backbone of rural health care, literally from sea to shining sea, and that's rural health clinics." And I about screamed in the back of the room. I was so happy that he noted that, but I thought that might not look good for us, so I didn't. But just the fact that he noticed that, I was very happy. Generally, though, the conversation does tend to be dominated when you talk about rural health. It does tend to be dominated about rural hospitals, which is fine. I love my rural hospitals. I love the work you guys do. I love the cause. Many rural hospitals own rural health clinics. But, I mean, it would be nice if rural health clinics, if primary care, outpatient care was noticed a little bit as well. So what that led to was we basically said, all right, this program hasn't been updated in many ways since 1977. So let's figure out all the things that we can do to modernize the program and, propose that to the Senate. And we sort of divided these items into two buckets. The first bucket was stuff that wouldn't cost money and be non-controversial, and that's first bucket one. So sort of no-brainer things. And bucket two was, all right, what's some stuff that costs money but are really vital for the program? So that's bucket two. All right. The first bucket, a lot of these changes, I'm not going to go through these individually, but a lot of these changes just update some of those requirements that you have to go through on the survey, for example. It makes it a little bit more modern because there's some stuff that we have to do that just doesn't make sense anymore. One example was that we have this requirement that the secretary list some drugs and biologicals that you might need in an emergency, and the drugs and biologicals were listed in 1977. They haven't been changed since, so there's things like emetics are on that list, which no one uses anymore. There's antidote is something that's on the list, and CMS recently interpreted that means everyone needs to have snake antidote, and we fought that, and we said that doesn't make sense. So instead of having the secretary list all the drugs and biologicals necessary for emergency cases, we sort of allow rural health clinics to figure out what they need in their particular scenario. So it's kind of turning some of that authority over to the RHCs. So that's just an example, but these are not deal breakers. They're just annoying things. That's why they're sort of uncontroversial and cost-free that we could fix, right? It's not going to cost Medicare money. It's not going to, be extremely, it's not going to be a game changer, like I said, but, it's a positive step. So we propose those, and those are in a bill that we hope will be introduced in the lame duck session, the Rural Health Clinics Modernization Act. If we can't get it introduced in the lame duck, we're definitely, we have a template to work from for the next Congress. And the more significant part, and I've previewed this a lot, is we have to address the cap. Now, this doesn't apply to critical access hospitals, but it is basically killing our independent rural health clinics if they want to see Medicare patients. Some of these independent clinics already are refusing to see Medicare patients, and they're just surviving off of that Medicaid rate. So that's not really a scenario we want to be in. We want to, reimburse appropriately on Medicare side. So the Act currently just increases that cap just by the amount seen on your screen, which would help, but I don't think it's the ultimate solution. This has been our policy for many, many years as NARHC, that we just increase the cap and don't pay for it. And because we don't have a way to pay for it, it has never gone anywhere in Congress. So we've never gotten the cap increase. That's why it was set in 1988 and hasn't been changed since, right? What we have recently done as an organization is say, okay, we need to come up with a way to pay for this within the RHC program, right? And we're working on some of those details now. We're trying to come up with a way that we can perhaps get everyone to a universal cap but not cut anyone. And that's a difficult proposition, but that is where we believe we need to go, because CMS and others in DC are looking at what they call these site neutral issues and saying that, hey, just because a hospital owns this office doesn't mean we should pay a lot more for the same service that a freestanding office provides. and we think that eventually this issue will come to RHCs, and someone will say, because this RHC is owned by a CAH or a small rural hospital, they can get $200 per visit, and this other clinic that's owned by a large hospital gets $83.45. Eventually, someone's going to highlight that, and we just don't think it's a sustainable program. At the same time, we're acutely aware that folks can't just get capped or out of the blue. We don't want to cut anyone's rate from where it currently is. So we're trying to work out all those politics and hopefully address this issue so that we're right-size Medicare payment within the RHC program. Last thing I'll mention here, this is a cost provision, is allowing rural health clinics to be a distance site. Currently, we can only be the originating site, at least when it comes to Medicare. Some state Medicaid programs allow us to be the distance site, but at least when it comes to Medicare, we can only be the originating site, which is where the patient is located. What we would like is for RHCs to be also allowed to serve as the distance site, which is where the provider is located. So this would change that as well. All right, I think I finished on time for questions. And there's my contact information. I'm always happy to take email questions, or folks can feel free to call and ask questions over the phone. Like I said, I do wish I knew more about CAUSE and Flex. So I might not necessarily know how everything that you do as Flex program coordinators, exactly how that translates to RHCs in every scenario. It's because maybe I don't know exactly what the Flex program coordinators do. So I'm trying to bridge this gap, but you have to help me a little bit too.
And we appreciate that, Nathan. And I think that is a good reminder about the January virtual knowledge group. That's another opportunity for Flex programs who are already doing work with rural health clinics through their cause to share some of the resources and technical assistance that you provide and some of the support that you're able to provide to rural health clinics. We'd love to hear from you in January, so please make sure you join us for that. And thank you, Nathan, for your time today. We really appreciate your information. Does anyone have questions for Nathan before we wrap up today? Okay, well, thank you again, Nathan, for your time. I really appreciate it. Before everyone hops off the call, if you could please take a moment just to complete the post-assessment to help us evaluate the webinar, I would really appreciate it. While you're doing that, I just want to wish you all a happy and successful National Rural Health Day tomorrow. And again, if you have any questions, please feel free to reach out to Nathan or us here at Tasc.
All right, thank you, y'all.